Dr. Fiedler, as you know, one way that we can lower prescription drug costs is by increasing access to generic drugs, which are often cheaper than brand name drugs. What are some of the barriers that keep patients from accessing low-cost generic drugs? And could you discuss how increased access to these medicines can lower costs for families and the federal government?
So there are, I think you can think about barriers at various stages of the process, right? So there's this stage of generic drugs being able to come into the market. There can be barriers associated with deals between generic manufacturers and brand manufacturers to keep the generic out of the market. And then there's challenges with, generic manufacturers actually navigating the FDA approval processes in order to get into the market. Because one of the things we know, while generic drugs clearly save a lot of money, it actually matters quite a lot how many generic manufacturers you have in the market. In terms of what those prices end up being.
Well, thank you. I've introduced something called the Increasing Transparency in Generic Drug Applications Act with Senator Paul, and that's a bill that would streamline the generic drug approval process and boost patient access to lower-cost medications, and the estimates it saves taxpayers about $1 billion over a decade. So I'll be looking for support on both sides of the aisle and both chambers for that. Dr. Fiedler, we are just 2 weeks away from January 1st when millions of Americans will be forced to pay higher health insurance premiums, which are doubling or tripling for some people, just in order to keep their coverage. The healthcare crisis here, as I noted in my opening, is because of inaction from congressional Republicans and President Trump. In light of the refusal thus far by Republicans, although, as I noted, the discharge petition got enough signatures this morning, but right now, our efforts to stop health insurance premiums from skyrocketing have really been stymied. Can you discuss how the Affordable Care Act increased access to preventive care and how cuts to it will undermine the goal of reducing healthcare costs?
So we have quite a bit of evidence at this point on what happens when people gain insurance or lose coverage.
Yeah.
And one of the clear messages from that is that being uninsured reduces access to care, including the ability to access preventive care. And the sad reality is that tends to translate into worse health outcomes down the road, including higher mortality rates and other adverse events.
Well, I appreciate that very much. I will save my last question for a question for the record, which goes to this issue of site neutrality and hospital ownership of physician practices and the impact on individual costs. And thank you, Mr. Chair.
Thank you, Senator. Ms. Malou-Tuckis.
Thank you, Mr. Chairman. Thank you all for being here today. Look, the fact is that since the Affordable Care Act took effect in 2014, the insurance company profits have skyrocketed by more than 230%, while insurers deny as many as 1 out of 3 claims while receiving billions of dollars in taxpayer-funded subsidies. President Obama, the Democrats who sold us this legislation as affordable, it was a bill of goods. Let's be honest about why we're in the situation that we're in today. And at the same time, premiums have gone up 96% since 2014, and they are projected to rise even further because if they don't have a COVID-era enhanced subsidy, that just shows you how unaffordable this really is on its own merit. Now, the truth is, I agree that we need a bipartisan solution to address this issue, and that is why I've introduced legislation with Brian Fitzpatrick and a couple of Democrats, so it's 4 Republicans, 4 Democrats, very bipartisan, that would address this issue to prevent the steep premium hikes for the nearly 24 million Americans who rely on the Affordable Care Act as well, including 80,000 in my district. But we also need to rein in these insurance companies, the insurance brokers, predatory PBMs, if we really want to drive down costs. So our legislation is a short-term solution, but we're here today because we want to pick your brains about what we can do to really fix this issue overall. And it does require innovative solutions. We have ideas like not just embracing and making sure we're covering innovation, but I have legislation on medically tailored meals. We can talk about incentives, and this is really, I think, one of the questions I'd love to hear Mr. Tingle, Mr. Roy, or anybody who wants to chime in on this. How do we incentivize better, healthier lifestyle choices to lower premiums, same way car insurers do it, right? if you take that defensive driving discount, if you have safety features on your vehicle, if you don't get in an accident in 5 years, you have lower premiums. I understand that some insurers are looking at doing this, but you have to ask for it, number one. Maybe we could do the same thing on the health insurance side with gym memberships, wellness programs, if you're a non-smoker. So my first question would be to anybody who would like to answer, Mr. Roy, on that issue.
Sure. So one of the things, I talk about this in my written testimony. So one of the things that the Affordable Care Act does is it actually makes it illegal for insurers to charge a different premium to someone who is healthier relative to sick. So the kinds of things you're talking about with car insurance, where if you're a safer driver and you don't get into accidents, you can get a lower premium. That's illegal in the ACA. The only thing the ACA allows you to do is charge a 50% surcharge if you're a smoker. That's it. One thing that they do in Switzerland that I would love for us to learn from, or a couple things actually. One is they allow for longer term insurance contracts. So instead of merely having 1 year of insurance, you could buy a 3-year plan or a 5-year plan. And that really incentivizes the insurer to invest more in prevention because they actually reap the rewards in that 3rd, 4th, or 5th year. If you only have 1 year with that customer and you put all this effort into prevention, you may not reap the benefit of if that customer switches plans later on. So what the Swiss allow you to do is they say, okay, you can have a 5-year insurance plan, and if you meet certain benchmarks like lowering your hemoglobin A1C, or you lose weight, or you reduce your blood pressure, then we'll actually refund half the premium. So that's something Switzerland allows that is now illegal under the ACA, and those seem to me like bipartisan reforms that could enable some of the incentives you're talking about.
Anybody else want to comment on that?
If I could just add quickly, I know it's a brilliant question, and the comparison to safe driving programs is quite fascinating, really. Like, incentives do work. I'll just give you one quick example. Our customers get points for the number of steps they take each day. And the point thresholds are 5,000 steps, 10,000 steps, and 15,000 steps. In my written testimony, you'll see a chart that shows the average step counts. Guess what? There's a huge spike between 5,000 and 5,100. Another spike between 10,000 and 10,100. People are trying to hit these things to get the reward. So now life insurers are in great position to think long term about these incentives. Health insurers, I think generally are speaking shorter term. I'm not an expert there, but it's why our industry, I think, can really step up here.
Okay, the senator mentioned vertically integrated insurers with medical practices. I'm very interested in their work in the pharmaceutical space. They're crowding out independent providers and limiting patient choices. Insurer-owned PBMs have also driven up drug prices, reducing competition and increasing costs on the consumers. I guess my question is for Mr. Fiedler. What steps should Congress take to crack down on predatory PBM practices in order to lower prescription drug costs and increase transparency for patients and independent pharmacies?
So I think one of the fundamental challenges we have in the PBM space is that there's just not very much competition. I'm not sure the problem, honestly, is vertical integration per se, and just the fact that there's 3 PBMs control a very large fraction of the market, and that allows them to extract a large payment for their services. I do think there are opportunities, particularly on the employer side, from a transparency perspective, of helping employers better understand the terms of the contracts they're signing, and hopefully finding ways to sort of get a better deal on behalf of their employees.
Thank you, Ms. Moore.
Thank you.
Thank you so much, Mr. Chairman, and it is so great to be here in the Joint Economic Committee. It's one of my favorite things, and to hear this prestigious panel, I've really appreciated and learned a lot from all of you. Mr. Tingle, I was very interested in your Vitality program, and it really focuses on the importance of prevention and early detection. Dr. Clark, you too talked about preventive visits at home and having at-home care being available to people with technologies that focus on prevention. Mr. Roy, you really lifted up how people avoid care and their worst outcomes when they don't have access and they don't have adequate health insurance, and it worsens the health care outcomes. And prevention is important. I have often complained because I don't think that the Congressional Budget Office scores prevention in a way that enables us to bring some of these innovative ideas to fruition. I appreciate Mr. Roy and Ms. Malatakis really lifting up the limits of Obamacare, where we can't use some actuarial data to provide lower premium costs for younger healthier people. That being said, I'm curious, Mr. Fiedler, about whether or not you agree with some of our members of this panel who have just blamed the increase in healthcare premiums totally on Obamacare. I think, Mr. Roy, you lifted up something called the original sin of the employer-sponsored healthcare insurance, where we have employer-sponsored healthcare insurance, we have the government doing Medicare, and then this huge gap of millions of people who, through no fault of their own, work for small companies and can't afford healthcare, and Obamacare brought in 24 million people. So do you agree that these healthcare spikes are just totally due to Obamacare?
I do not. I think one of the things I said and discussed in my written testimony is that if you look at the premiums that we see in the ACA marketplaces, they're comparable to the premiums we see in employer coverage. So these plans are expensive because American healthcare is expensive, and that has a whole variety of causes. But it's just not accurate to argue that these premiums are high because of the ACA. The other thing I would point out is, we've had a pretty remarkable 15-year period where healthcare as a share of GDP, so healthcare as a share of our economy, has barely risen, which is a stark contrast with the decades that came before. I don't think the ACA deserves full credit for that trend. I think there's a lot of things going on. But I think the argument that the ACA has created this explosion in healthcare costs, it's just very difficult to reconcile with the macro trends in healthcare costs that we've seen over the last decade plus.
Our chairman talked about how 31% of Americans have diabetes, which is a very costly disease. I've seen it personally. Insulin and dialysis and amputations, and prevention would interrupt this trend. I also would like to see the GLP-1s being funded not for people who just want to be slim on the beach, but people who are morbidly obese, and that would lower. These are some technologies that I think could help. Can you all talk to me about that? Oh, and also, Mr. Fiedler, you talked about the public option and reining in antitrust laws and the public benefit managers. I want to yield some time for you to weigh in on how these reforms might help us.
So on a public option in particular, I think, one of the challenges, as I talked about, is that the prices we pay for healthcare are quite high. And one of the interesting comparisons, if you look at what Medicare pays for hospital services, Medicare pays less than half what private insurers typically pay. They pay for physician care, they pay about 3/4 what private insurers pay. And so I think this does raise the question of, would people who currently get their insurance on the private market be better off if they were enrolled in an insurance product that determined prices for care more similarly to Medicare? I think there are a whole lot of considerations there, but one of the rationales for a public option really is trying to bring down the prices that people pay for care.